Hey there, students. Professor Zeeb here, and welcome into another video lecture. This time we're going to hit chapter 5, and let's get right to it. Let me get my slides up here. All right, chapter 5. So chapter 5 is going to cover various disorders. So that would include anxiety, trauma, and stressor related, and obsessive compulsive and related disorder. So there's a few different ones that are covered in this chapter. For this lecture, we're going to focus mainly on anxiety, but we're going to start off defining some terms and get you going on the chapter. All right, so let's go to the section in the book there, anxiety, fear, and panic, some definitions. So when it comes to anxiety, the way we would sort of define that in psychology is a mood state marked by negative affect, symptoms of physical tension, and apprehension about the future. In other words, when it comes to anxiety, the person is anticipating a future danger or some type of misfortune. It's very difficult to study because it can be quite subjective from person to person. It's often studied in animals, which is controversial. However, it is a little bit tough going in terms of trying to study this one. All right, so anxiety may be expressed as subjective unease, worried behaviors, and or physiological responses. So some examples of that would be like elevated heart rate, tension in the chest, the person is avoiding situations, for example, okay? So it can be expressed in different ways. Really, there's two ways we can look at anxiety in psychology. So the first one is that anxiety is adaptive and normal. So I think in this case, we're saying it's more in a moderate version of that. So the anxiety level is pretty moderate. And so what we're finding with a lot of people is that it creates a future-oriented state that prepares us for action. In other words, if we have a little anxiety, which is obviously considered to be normal human experience, it may motivate us into action. It may actually help us in certain circumstances. So studies do confirm that. Research shows that we perform a little better when we're moderately anxious or a little bit anxious. So, for example, if you have an exam coming up and you're a little nervous about it, it may actually motivate you. It may motivate you to perform better on a job interview, for example. So, like I said, in this case, we're saying that it's moderate, so it's not excessive in any way. However, anxiety can definitely be problematic when it's in excess because it may interfere with important areas of life functioning. For example, your social life, your ability to hold down a job, for example, um, attending class could be an example of that. So, for example, if the person has a lot of test anxiety and it's really excessive, it may create problems concentrating on the exam where you're not performing like you normally would. Okay. Or if it's a phobia, it could actually limit your lifestyle and prevent you from doing things and living life. We're going to find that there's a lot of disorders circling around anxiety that involve it in some way, one way or another. And typically we're going to say it's more excessive. So when it's excessive, then it's impairing the person and it's creating problem. Like I said, when it's moderate to small, we would consider that to be more normal. Okay, so now we're going to compare it to fear. Okay, so a lot of people think these are synonymous. They're actually a little bit different. So with fear, there's an immediate alarm reaction to dangerous, life-threatening situations. And that would basically trigger our fight or flight response, which, as you probably know, stems from the sympathetic nervous system. So fear is often characterized by strong avoidance behaviors or what we call escape behaviors where the person is trying to flee a situation in some cases. Research definitely shows that fear is different than anxiety, even though there's some common factors. Anxiety seems to be more of a future-oriented state of apprehension, where fear is more immediate emotional reaction to current danger associated with strong escapist type behaviors, as well as a surge in the autonomic nervous system. So to me, in general, I mean, there's exceptions to this, but in general, anxiety is more future oriented, like something horrible is going to happen to me, where fear is more in your face, sort of present, where there's an immediate threat that is justified. Okay. So there's a little bit difference between the two, and we do distinguish those in psychology. Sorry, guys, I'm having trouble with my mouse here. So there's two ways to view fear, as you can see, a normal emotional response that is adaptive. For example, it may allow us to escape a danger or a threat. So for example, if there's a venomous snake you see on a trail, it allows us to escape that situation so we're safe. Fear can also be problematic, okay, because it could get to the point where it's interfering with your daily functioning when it's experienced in excess. So you can see there's a lot of commonality between fear and anxiety, but once again, we kind of look at those differently in the class. All right, something else that could accompany anxiety is a panic attack. In fact, we have a whole disorder surrounding this, but panic attacks can certainly occur in other situations. It's kind of interesting where we get the word panic from. It comes from the Greek word meaning Pan, who is the Greek god of nature. I guess there's apparently a story surrounding it where this god who was not very good looking, for example, went to live in a cave and went to sleep. And some travelers discovered the god and awoke him suddenly, and he awoke with a blood-curdling scream that actually scared the travelers to death. So there you go. You can see the connection with the panic attack to the point where, you know, you're frightened and you feel like you're going to die. Basically, it has those sort of roots in Greek mythology. So in psychology, panic attack is an abrupt experience of intense fear or discomfort accompanied by physical symptoms. And in most cases, I think what we're saying here is that there's nothing to be afraid of, or it could be a false alarm, for example. So the person could experience various physical symptoms. I'm just going to read some here. So those could include chest pains, heart palpitations, shortness of breath, dizziness, sweating, nausea, chills or hot flashes. Okay. And so I can see that it's pretty intense for the person when they're going through a panic attack. To kind of give you an indication if you've never had one, so by the way, I'm not advocating this anyway. I'm not requiring you to do this or saying that you have to do this, but I just want you to use your imagination. So if you took one of those little coffee straws, you know, those little thin coffee straws that you get like at Starbucks or something, and you put that in your mouth and then you jog in place for 60 seconds. Once again, please don't do this. But if you can imagine doing that and trying to breathe through this little straw as you're exerting energy, that's kind of what it would feel like to have a panic attack where you can't breathe. You would probably feel dizzy and not quite right. So, just as an example, that's kind of what we're talking about when a panic attack actually hits. There are two types in general of panic attacks. So we have what's called a cued panic attack. So this is sort of expected in a given situation and is bound to some situation and not others. So for example, the person could have panic attacks in social situations. I guess what we're saying is that the social situation is cueing or triggering the panic attack to occur, but they do not experience it alone. So in other words, It's surrounding the situation, in this case, a social situation, but it doesn't happen in other situations. This is common in people suffering from specific phobias. So it may surround a specific thing or event, or the person is having panic attacks, when they encounter snakes or they're on an elevator, for example, just as an example. In other words, it's being queued up. The second type would be more unexpected or uncued, as we would say. So this is unanticipated. So it kind of like comes out of nowhere, without warning and hits the person, and is very common of something that we call panic disorder, which we're going to talk about in the lecture. Okay. So in some cases, it's more cued or expected. In other cases, it's more sudden and surprising to the person. All right, so now we're going to look at what sort of happens when someone has a panic attack. Book gives some great illustrations of this. So this first one we're going to look at is the heart rate of the person. So they're measuring the heart rate of the subject during a panic attack. So down here you see the time in minutes, and then the actual heart rate here on the axis on the left. So there's a baseline where that's kind of like their normal heart rate, and then they're in a relaxation phase. So notice the heart rate goes down, but then around minute 11, the panic attack hits. And look at this jump. Look at this big difference in their heart rate from minutes 11 to 12. It really shows how their heart rate is increasing big time, especially at the onset of the panic at the beginning. This next graph shows a frontalis EMG, which basically measures muscle tension. So you kind of see the similar findings that we saw before with the heart rate. There's a baseline, a relaxation state. And then once again, we see this jump from minute 11 to about 13, where the person is feeling very tense in terms of their muscles. All right, and then finally, temperature reading of the same time frame. So we see the baseline and then the relaxation state. Notice that the temperature is going down prior to the attack. And then around minutes 12 or 13, we see this jump in temperature, and then it basically stabilizes. So note the temperature was actually decreasing prior to the attack, and then the autonomic surge peaked and then leveled after 3 minutes around minute 14. So keep in mind, these attacks often appear very suddenly and unexpectedly, where the heart rate goes up. We see tension, muscle tension, for example. And so it kind of gives you an indication of what it's actually like to have a panic attack. All right, so we're going to move on. And next, we're going to talk about the causes of anxiety disorders, some general causes that we've noted in anxiety. And there's quite a few. So essentially, a lot of it's surrounding biological causes. So there are multiple causes in its nature, but we're going to look at biological. So we know that people can inherit the tendency to be anxious or even to be tense and uptight. So we think it runs in families, and that has been identified in research. Results from contributions of several genes. Some of the chromosomes that have been focused on are chromosomes 1, 12, and 15, seem to be the key players in terms of inheriting anxiety. But we think that if you inherit this, it produces a vulnerability in the person, especially if the right social and psychological factors are present, which we're going to talk about. So, I mean, really, stress is what's going to trigger it. So the person has inherited the tendency, and then they go through a stressful situation, and then it sort of explodes into anxiety. All right, we know that anxiety through research is associated with specific brain circuits and neurotransmitters, which we're going to talk about. So the first one is GABA. GABA is an inhibitory neurotransmitter. So we know that depleted levels of GABA are associated with anxiety. It's also implicated in norepinephrine and serotonin systems. So a lot of research has revealed that those two particular neurotransmitters are involved. We also see evidence of the corticotropin releasing factor system. So the focus in research are the genes that actually turn this on. The system seems to control our expression of anxiety. So the person may have some kind of biological factor that disrupts that system. And it's involved in something called the HPA axis. So more specifically, the hypothalamic pituitary adrenal cortical axis, quite a mouthful there. In other words, it's involved with the hypothalamus, the pituitary gland, and the adrenal gland, as well as the cerebral cortex. Okay. However, the area most associated with anxiety seems to be the limbic system. And so the limbic system, what it does is it helps to mediate information from our cortex, which is receiving information from our environment, for example, and the brainstem, which monitors body functions. Okay, so it's involved in that sort of um, interplay, if you would. And so that leads us to something called the behavioral inhibition system, which was discovered by Jeffrey Gray, which is activated by the brainstem and allows us to sort of pause when we encounter threatening or dangerous situations. So, for example, when our BIS is activated, we tend to freeze or pause, experience anxiety, and then apprehensively evaluate the situation to confirm if danger is present or not. So it interacts with higher levels of the brain, higher level areas of the brain, but also the brainstem, as we said, to kind of figure out, should we be nervous? Should we be anxious about this situation? So, what the research is basically showing is that people with anxiety disorders often have an overly responsive limbic system, as it turns out, as well as the amygdala. And so they have difficulty controlling the functions of the cortex that would downregulate those excitable instructions. So, in other words, what we're saying is that the system is a little bit sensitive where it has trouble sort of controlling and really thinking through, is this an immediate threat? So, thus, it allows the person to um, jump into an anxious state, which obviously can be problematic. All right, so once again, we see a lot of biological influence of that one. Now we're going to look at psychological contributions to anxiety and look at some different theories. So I'm assuming you've read chapter one. This is a great chapter to kind of think about this section here. We're going to start with Freud and his explanation of anxiety, which is controversial. But Freud saw anxiety as a psychic reaction to danger surrounding the reactivation of an infantile fear situation. In other words, there's some type of unconscious conflict that stems in childhood, which manifests in anxiety. And so it may have been repressed initially, repressed meaning sort of swept under the carpet, or, we call it motivated forgetting. The person did not deal with it when it happened, or when they were dealing, when they're experiencing it. And therefore it manifests as anxiety symptoms. And so in therapy, they would attempt to uncover that to allow the person to deal with it consciously. Okay, so next we go to the behaviorist, so a different theoretical perspective of anxiety. And so the behaviorists, what they're going to say is that it's a product of classical conditioning or potentially modeling or even operant conditioning. So in some way, it's being maintained through a learning type situation. So, for example, if the person has ophidiophobia, a phobia of snakes, they may find it very reinforcing to remove themselves from a snake. So, for example, if they encountered a snake and they ran away, they would note that my heart rate immediately goes down once I do that. You could almost argue that's like positive reinforcement because if I do this, then I feel better. Okay, or I mean, you could also argue it's negative reinforcement because it's removing the anxiety. So, in other words, it's learned in some way through reinforcement, you could argue, through escape type behaviors, but it could also be maintained by watching someone act this way, the modeling aspect that we see from Bandura, but also be associated with different things through classical conditioning. So, once again, different schools of thought of how that sort of happens. We also see evidence of social contributions to the development of anxiety in general. So, stressful life events often trigger vulnerabilities to anxiety and panic. In other words, a lot of times we see that there's some kind of stressful event that's happened in the person's life, and that's really where the anxiety becomes a problem. So, it could be like going through a divorce, for example. Maybe they lost a loved one, which obviously would be very stressful. It could be a work related issue where they're stressed out about work or they've been injured, a whole host of different problems that are stressful. And that seems to trigger the vulnerability in the person to experience anxiety. They've also discovered that the way we tend to react to anxiety in these types of situations does run in families. So, for example, if you've been known to get stress headaches when things go wrong, there's a good chance that people in your family also experience stress headaches. So we see this pattern, this familial pattern, in terms of how you react to stress. So that also suggests that there's a genetic component, but obviously that could be learned from the environment at the same time. Okay, childhood influences. So a lot of times we see childhood influences on the development of anxiety. So in childhood, we may acquire an awareness that events are not always in control and are seen as danger. So maybe the child was not taught ways to deal with stress or to deal with threatening situations, and therefore it seems out of control to the child. Our sense of control often emerges via interaction with our parents, right? So we know that parents who are overprotective and over intrusive in a child's life may not teach the child self-regulation skills, which obviously we need as an adult because things are going to go wrong. I mean, being human, so we need ways to cope with that eventually, right? So maybe the parent never taught that to the child, so they go through life without these skills, and unfortunately, it sets them up for experiencing anxiety. So the child never learns to cope with adversity on their own and may learn a lack of control where it's sort of internal to them, where they feel like there's nothing I can do to stop this. So we really think that makes children vulnerable to developing anxiety disorders down the road. We have found that parents who are responsive, allow children to explore, and also are very positive about life often establish control in their child's life, and those children often learn to cope with adversity much better. So once again, parent, if we look at child and family sort of influences, it's important for parents to instill these values in their kids and to give them skills to cope with life later on, because obviously they're going to need that. Furthermore, in general, with anxiety, you could also see that it can be an integrated cause or a combination of psychological, social, and biological factors. So we've already mentioned that all three of these areas seem to be important to developing an anxiety disorder. But in a lot of cases of people who are struggling with anxiety, we see evidence of all three. In other words, it's almost like a recipe for disaster when they're all present and in combination and makes it intense for the person. So, for example, there could be a biological vulnerability, as we said before, just kind of looking at this chart here, where they've inherited the tendency to be anxious. But once again, alone, that may not be sufficient to produce an anxiety disorder. They may have a generalized psychological vulnerability. In other words, they believe things are out of control. The world is dangerous. I cannot cope with stress when things go wrong, right? So it's a more generalized vulnerability that the person has experienced, as we said, through family life. It could also be a specific psychological vulnerability. So maybe they've learned through specific situations that certain objects or certain situations are fraught with danger, even if they are not, by the way. And so it produces these cues or triggers to the person to be stressful. So as you can see, if all of those are present in the person's life, so they've inherited this tendency, they weren't taught coping skills, or they believe the world is dangerous. All of that in conjunction or in combination together, once again, sounds like a recipe for disaster in the person and makes it more likely to push them over the edge where they're actually experiencing anxiety in terms of being a disorder or a problem in their life. So once again, classic nature nurture, as you can see, a lot of moving parts there to kind of consider. All right. So now that we've established the causes and kind of the background, we're going to get into a couple of the anxiety disorders. You'll read about those and look at those in the information I've posted in Canvas. You'll look at that. Please make sure you read those, the information posted in Canvas. But let's take a look at some anxiety disorders here. So the first one we're going to examine is simply called general anxiety disorder, or GAD. Okay. So this is characterized, as the name implies, by an intense, unfocused type of anxiety. So, in contrast to say something like, like a phobia, for example, this is, where it's tied to a specific thing or event. In this case, it's more general and sort of, it's sort of looked at in many different areas of life, including their health, their sleeping habits, maybe it's school, work. They worry about everyday life events. In other words, it's a more general feeling of anxiety rather than being tied to a specific situation where we would see that in a phobia. Okay, so here's our DSM-5 criteria for a generalized anxiety disorder. Psychologists would have to establish that it's at least 6 months of excessive anxiety and worry. In other words, it's difficult to control or turn off for the person, and it's lasted a pretty sizable chunk of time. Our symptoms, which could be different from, say, panic, muscle tension, which is chronic, mental agitation, so being on edge, susceptibility to fatigue, irritability, difficulty sleeping, and difficulty focusing attention. So remember, this is someone who worries about everyday life events for the most part. See, most of us do worry about life, right? That's part of being human, is worrying about everyday life, but we're able to set it aside. We can get past it pretty easily. It bothers us for a little bit, but then we're able to sort of move on. So in this case, the person is really focused on that and unable to kind of get rid of it. So it would be more persistent or chronic in that sense. Okay, so let's look at what the statistics of GAD are according to research. Turns out it's pretty common. So according to our studies, approximately 3.1% of the population will have GAD in a given year. Approximately 5.7% of people will experience GAD at some point in their life. So once again, those are considered to be pretty common estimates or statistics. We know it's pretty common in the elderly population. Okay. In fact, it's most common after age 45, but certainly can occur earlier. It seems to be more common in females. Some people believe that's because of cultural reasons. The onset is usually early adulthood. Okay. So it is usually early adulthood. However, our median onset is around age 31. Often responds to some life stressor. So, in other words, the person seems sensitive to a personal threat of some sort, as we said before with the different examples. It also has a more gradual onset compared to some of our other anxiety disorders. In other words, we would kind of expect it to wax and wane throughout the person's life, but certainly it would follow a chronic course. It would be more persistent than some of our other disorders. And once again, it seems very prevalent in older ages, if you would. Okay, so what causes GAD, general anxiety disorder? Like a lot of disorders, we see a lot of causal factors involved. Some of those would be genetics. We know that it runs in families, and certainly twin studies have confirmed this. We know it's more common in monozygotic female twins than fraternal twins if one twin already has it. So, monozygotic twin meaning identical twin compared to, say, fraternal twins. However, what seems to be inherited is the tendency to be anxious or become anxious and not actually the GAD. Some people view GAD as autonomic restrictors, so GAD people are often referenced as this, which basically means they show less responsiveness to stress compared to others with anxiety disorders or other anxiety disorders. For example, heart rate, blood pressure, etc. However, the one critical factor, especially where panic is prominent, seems to be chronic muscle tension. So that's one of the most distinguishing factors is chronic muscle tension. So that really seems to be the only uh, distinguisher among those symptoms when we compare them to other anxiety disorders. Okay, so let's take a look at this chart. The book gives this. So when it comes to GAD, generalized psychological vulnerability, generalized biological vulnerability, often triggered by stress or some life event, or and in some cases a false alarm where there's no threat. It involves anxious apprehension, including muscle tension, as we said, is one of the distinguishing factors. The person goes through a worry process or a failed attempt to cope and problem solve the issue. Intense cognitive processing and inadequate problem solving skills. But they've also discovered in research that it may be avoidance of imagery surrounding the threat and a restricted autonomic response. So let me kind of explain that. It may result of an autonomic bias for threat coupled with a lack of processing the associated imagery and the emotional components of that imagery that would normally elicit strong autonomic responses. So the research is kind of showing that they may avoid imagery of the actual threat. And so we think that that may be part of processing it is you need to kind of imagine it and picture it to be able to work through it. So there may be some kind of disruption in that process. So once again, when we look at brain research, they may engage in frantic, intense thought processes without reference to the accompanying images of the actual threat. Okay, how do we actually treat GAD? So once again, it like a lot of disorders, it's going to be a combination of medication and therapy. So the treatment of choice with medications is benzodiazepines, which are minor tranquilizers. These are really good for the short term, like meaning 8 weeks or so, may not be as effective in the long term, but we need more research to kind of confirm that. Okay. The problem with this is that, it's a medication, it is a tranquilizer, so it's going to impair motor skills and cognitive functioning. So there's side effects of those. It can also lead to dependence and addiction issues. So it's kind of like, hey, we're solving one problem, but we're creating another, and that's dependence. And obviously, we want to consider that. Antidepressants are also used to treat GAD. So different medications are used. Psychologically, which, as it turns out, are pretty almost, well, as effective as a drug treatment. Some sort of psychologists believe it's actually better in the long term than using medication. So in this case, what they would do in therapy is focus on the worrying process. Okay. So, in other words, establishing coping techniques or a cognitive behavioral technique to help them to get through the worrying, but also acceptance of anxiety rather than avoiding anxiety, accepting anxiety, and couple that with relaxation techniques and even meditation. So new treatments focus on accepting rather than avoiding distressing thoughts and feelings. So they may get the person to use meditation or more mindfulness techniques to help the client be more tolerant of the feelings of anxiety rather than trying to fight it. Okay, so let's move on to our next disorder, and that is simply called panic disorder. So once again, another type of anxiety disorder, but in this case, it's going to involve panic attacks, as we described earlier. This one's sort of dangerous because it does have some connection to suicide. So we want to consider that, obviously. But panic disorder, which, by the way, can also accompany what we call agoraphobia, and we'll talk about that. So panic disorder is where the person experiences unexpected panic attacks. And we talked about the different types of panic attacks. So in this case, it comes out of the blue. They're not ready for it. And they develop anxiety about the possibility of the next attack. In other words, the person's had an attack, and then they're starting to worry about when the next attack is going to hit, which creates anxiety, as you can imagine. So maybe anxiety about when the next attack is coming or the implications of what the attack is. In other words, it's going to embarrass me. I'm going to have a heart attack during this episode, et cetera, et cetera. So, as we mentioned, panic disorder can occur with or without something called agoraphobia. Okay. By the way, agoraphobia, if we look at the technical meaning from the Greek language, it means fear of the marketplace. More specifically, however, it's a phobia where the person is avoiding unsafe situations, and in this case, where a panic attack may occur. So, for example, maybe a tunnel, a train, out in public where they can't escape or they cannot deal and cope with the attack appropriately, where it creates problems. So it may embarrass them. They may not be able to escape, as we said. In some cases, the person may not leave their house as a result of that because of the anxiety surrounding that. It seems to be a complication of severe unexpected panic attacks. So, like I said, if you've had an attack, you may prefer safe places to have future attacks. So, in other words, it may be a lot easier to cope with if I just stay home rather than going out in public, because then it happens. I won't get embarrassed. I can cope with it. It's more comfortable. It's a more comfortable environment, is what I mean by that. And so I can cope with it better. Agoraphobia can become independent of a panic attack. Okay. So we do have evidence that agoraphobic tendencies can still be present even if the panic attacks have not occurred for years or may have never even happened. So, in some cases, it can be completely independent. It could be that agoraphobia could be a form of coping behavior of the actual panic attacks. In other words, that's how they deal with it, is they avoid situations, okay? Agoraphobia seems to be determined by the extent to which you think another attack will occur, rather than the actual frequency or severity of attacks. All right, going to our next slide with agoraphobia. Must be characterized by either avoiding situations or by enduring them with marked distress. So in other words, this person may live their life with intense dread. Interoceptive avoidance is another thing we would look for, which is shown by agoraphobics, which is avoidance of internal physical sensations, which may remind them of having a panic attack. In other words, we found it's pretty common for someone who has this to remove themselves from situations or activities that might produce physiological arousal, because that often resembles what happens at the beginning of attack, as we talked about early in the lecture, where the heart rate goes off the charts, the muscle tension. So they may completely avoid situations which would create those symptoms because it may sort of remind them of an attack or may worry them that an attack may actually be about to happen. So, for example, they may avoid exercise, or because it elevates their heart rate. They may not go in a jacuzzi, for example, because it makes them sweat, and that happened before with a panic attack. So we find that oftentimes they avoid those sort of situations. Okay, next we go to the statistics for panic disorder. Fairly common fairly common. It is 2.7% of the population within a given year, and then 4.7% in a lifetime. 2/3 are women. Okay, so we know that the majority of them are female, but not all of them. Average age of onset is early adulthood. So if you looked at a range, it would be from your teens actually up until your 40s is the most common age. However, our medium age of onset is between 20 and 24. So in other words, the average, if you would, if you look at the actual median without the extremities, the outliers, it would be like young person, 20 to 24. We do see some cultural differences. For example, we know that panic disorder exists worldwide, but the expression varies from place to place. In other words, symptoms may be different, from crying, shouting, ignoring dread feelings. So kind of depending on where the person lives and the culture that they're exposed to, the expression of the symptoms may be slightly different. Okay, causes of panic disorder, they are numerous in nature. Interaction of psychological, biological, and social experiential influences, very similar to what we said, anxiety in general. So vulnerability to stress is inherited, or a sensitivity to overacting to life events. This may create an emergency alarm reaction where the person has an unexpected panic attack when faced with stress. Predisposition to associate a response with internal and external cues. So once again, very related to what we said before, where they may get cues of elevated heart rate and creates an assumption that a panic attack is about to happen, or they may associate it with certain places. Like, for example, if they went to a concert and they happen to have an attack at a concert, through classical conditioning, they may associate the attack with a concert, and therefore that becomes a trigger. So they may avoid concerts as a result. Psychological vulnerability to catastrophically misinterpret such events and develop anxiety over the possibility of future panic attacks. Once again, a lot of the information that we've already stated here. So it could be misinterpreting cues, worrying about future attacks, which seems to sort of trigger them. Okay, treatment of panic disorder. Medications are definitely used, but like we saw with GAD, there's side effects. Benzodiazepines or tranquilizers. Xanax is used. Probably our most widely used medication is Xanax. SNRIs, so serotonin norepinephrine reuptake inhibitors. As we said, those are often involved with anxiety disorders. SSRIs are often used as well. Okay, and then psychological interventions. Exposure therapy is often used with panic disorder. So maybe we expose the person to a situation that may cause a panic attack. And so it helps them kind of deal with it. So it kind of shows them that it's not going to happen. As we mentioned before, if they had one at a concert, they had an attack at a concert, we may purposely expose them to a concert to show them that it's probably not going to happen. So in other words, they may create a hierarchy where they gradually expose the person to the situation or trigger that typically creates the panic attack. All right, also in therapy, we would use anxiety coping mechanisms and exposure therapy in combination, and that has some pretty good success rates there. All right, so we're going to go ahead and stop there for our lecture. I'll let you kind of read about the rest of that in the book there. So I'm going to go ahead and stop the recording.